Alzheimer's Auckland board, as well as being a lecturer in health law and ethics at AUT University. Today she shares her insights into the topic of advanced care planning for people with dementia, something that challenges and scares many carers and people with dementia. Would you please make welcome Kate Kersey.
Hello, what a big group. My daughter actually goes to this school, so it's a completely strange experience to be here, talking to you all here, but it kind of has a nice comforting feel as well. The one thing that in the introduction that you didn't actually quite express before, you might not know, is that I also live with I don't live with her, but my mother also has advanced dementia. And so not only is it a professional topic of interest, but it's also a personal topic of interest. So first of all, thank you all for inviting me here to speak today. And I can see that you're a really diverse audience. And I suspect that there's probably more people here with a personal experience of dementia rather than a professional experience, although the people that our carers should also be recognised for having both a personal and professional role in the amazing care that they provide. So I've been invited to talk about advanced care planning and dementia. Now looking at the program, you've had some wonderful talks on how to live well with dementia, and it's a fantastic focus, but this talk perhaps shifts a little bit to a focus on planning for the end of life. As a progressive illness, and something that unfortunately, even though it's not actually a disease of ageing, it is correlated with ageing, you're more likely to get it as you age. This is a reality that we all must face. But the intention of this talk is positive. It's about considering how we give people with dementia and their carers a voice in these issues, and how to place dementia in the context of a life that's been richly and purposefully lived and still is. I think that's really important. We've seen the most dramatic advances in medicine and technology, of which we all benefit on almost a daily basis. For example, people with hypertension and vascular disease have many treatments available to them and have thwarted the diseases that probably took their parents. However, in his recent book, Being Mortal, Atul Gawande, a surgeon, a writer, an academic, has queried whether our medical technology might have actually limited our conversation on the dying process. With medical technology, we're always trying to fix something, and it can be harder to acknowledge that there actually is an inevitability about the ageing process and the dying process. So he says, in the past few decades, medical science has rendered obsolete centuries of experience, tradition and language about our mortality and created a new difficulty for mankind, how to die. Now, I've got no, obviously, financial interest in this, but I do highly recommend that book as reading for you. So I think it's really important to keep this in mind when we consider advanced care planning, because we need to think of why we're doing it. And our aim must ultimately be, for all of us, those of us with dementia and those of us without dementia, to be how do we achieve a good death in line with our values of respect, dignity and compassion. So with that in mind, oh, there we go. Okay, what is advanced care planning? Who in the room is familiar with advanced care planning? Okay, so maybe about half of you, a third of you? Okay. So this is a wonderful woman called Colleen Cartwright, who's a professor and also has her own company in Australia, who's written some work. I think she was commissioned by Alzheimer's Australia, and she's written a couple of documents on this. Now, if you're interested, be careful reading them, because the law in Australia is different from here, just so you know that. She gives a really great definition, and it's planning future care to to ensure that your wishes are known when you no longer can make decisions for yourself or legally complete documents. Because what we do know is over the course of the diagnosis with dementia, at some point, people do actually lose their capacity to make medical decisions. A diagnosis of dementia doesn't mean immediately you have no capacity. That's not true at all. You actually, because of the disease and the treatments that we have and the way that we live, you can have a very long time when you're actually still legally entitled to make decisions for yourself and able, you're considered competent and have capacity to make these decisions. But at some point, it's very highly likely that you'll enter a phase where you don't actually have the capacity because you don't understand the true nature of the decisions that you're being asked to make. So in general, and this is what all the people writing about it, it's considered highly relevant for people with dementia because of this fluctuating capacity and changes over time. So let's have an everyday example, and some of you may be able to relate to this. Let's take Susan. She's recently been diagnosed with mild to moderate dementia, but she's still at home, able to make decisions, is enjoying a good life. Her husband still takes care of her for the most part. Now, she discusses this with her husband over coffee and breakfast one morning and says, I really don't want to be hooked up to machines at the end. You know, when I get to that point, I don't want that. I don't want that kind of life-saving treatment. And I really want you to assure that that's going to happen. Now, I think this is probably quite a normal conversation. In fact, my dad took it on himself out of the blue, not even knowing I was doing this talk today. He took it upon himself to tell me that yesterday. So I thought, well, we might have to actually write that down somewhere there. But now, 3 years later, her dementia has become advanced. She's been admitted to hospital level rest home care, and she needs treatment for pneumonia. So what does her doctor do? She said she doesn't want life-saving treatment without the drugs for pneumonia. She probably won't get well. But she's not actually hooked up to life support machines. So what did she really mean when she said, I don't want life-saving treatments? And I think this is a really good example because I think this happens all the time. It happened to me yesterday, as I said. This happens all the time. So we need to actually think about what do we do about these statements? What do we do about people's wishes? How can we make it legally binding if that's what people want? And also, if circumstances really do change, what do we do about that? If we're not sure that's what someone would want anymore, what do we do about that too? I'll probably raise more questions than I'll answer, but the good news is I've got my email address at the end, so you can always email me. What on earth were you talking about? I know it was something about advanced care planning. Okay, so when we're thinking about advanced care planning for people with dementia, we can ask ourselves some questions. And the first question might even be, are we comfortable with advanced care planning for people with dementia, especially because of that long lead time? And I'll go into a little bit more detail about the special features of dementia and how it impacts on advanced care planning. And then, because academics want jobs, we might say, well, what does the health research tell us? There's been a lot. I got volumes and volumes of reminders in my office of studies that people have done about advanced care planning generally and even about advanced care planning with dementia. What does the law say? That's always a good start. Because despite all these questions, the law is definitely in favour of advanced care planning. And so if we've even got to that point, well, how do we go about it in New Zealand? What's going to be our way of approaching it? Okay, so advanced care planning is alive and well in New Zealand. Do not resuscitate orders frequently on people's file. Those with enduring powers of attorney are often asked to make them, which I don't actually think they can, but we'll get to that. And often doctors also are able to put them on people's files when they feel that further treatment would be futile. We've had the National Advanced Care Planning Cooperative. That was a huge amount of work by the Ministry of Health and the Auckland District Health Board. They put a lot of work into that. There's some great publications online. And even our own umbrella organisation has a section on its website about planning for the future. So it's very much alive and well. Okay, so let's actually think about, let's get a bit more practical now, and let's think about what are the components of advanced care planning. So the first component is having the discussion. So there's two components in that discussion, and Margaret rattled them off for me before, without probably even knowing it. It's about your care preferences. And so then you might want to document your care preferences. So how are you going to do that? You'll write an advance directive or a living will. I'm sure most of you have heard of those. You'll write it now when you've got capacity to apply later. And we also might think about who do we want to be our substitute decision maker. Well, probably, if it's going to be one of your children, if you've got some to choose between, you'll probably choose the one that actually is going to do what you want them to do. You won't choose the one that says, oh, Mum, I'm never going to let you go. Because, or you will choose that one, if that's what you want. That's the idea. Get it all lined up. So, the relevant documentation in New Zealand that you'll be considering are advance directives and enduring powers of attorney for personal care and welfare. I hold an enduring power of attorney, and I probably should actually, Barbara said to me, you should actually have one for yourself as well. So, sport taken. Yes. Okay. So, why do we want to do advanced care planning? Why do we all talk about it? It's this idea that we want to respect people's autonomy, their right to self-determination at the end of life. We want to have them achieve better care at the end of their life and less emotional distress. Now, the reason I picked the picture of the cat, it's not just because I really love cats, it's because at my mum's rest home, there's a person there that has these two Burmese cats, which are so old they probably need advance directives as well. I picked one of them up the other day, I think weighing about 2 kilos. It's just those beautiful cats. And they're obviously someone's precious cats that they've had and have lived with them for a very long time, judging by their age. And that person, if they get to choose where they wanted to die, choose to have aggressive, it's called terminal hospitalisation at the end of life, you'd much rather, I'm speaking for them, but you could consider, you could conceive that it would be more important for them to be at home, surrounded by the things that they know and love, than hospitalisation. And there's also evidence, there's an awful lot of, all those volumes that I just told you about, that I'm like, what's there? I have just made them up. Reduce stress, anxiety and depression for carers and family, limit unwanted treatment, reduce hospitalisation. I've got a question mark next to increase cost-effective care. So some really brave academics have actually started doing some research into that area, which just makes me uncomfortable. But anyway, someone else is doing it. Okay. Advanced care planning is a little bit easier when you think of someone who has a car accident and is all of a sudden on life support, and that really medical treatment's futile. It's just a little bit, there's some slightly different features of dementia that make the conversation a little bit more interesting. The first is that there can be a lengthy period of incapacity. From a diagnosis of dementia, people can be many, many years. And that capacity can actually fluctuate. And as you all know, there can be personality changes. A very famous philosopher gives an example of a woman who is, say, a concert pianist and develops dementia and says when she develops dementia, I don't want any life-saving treatment, I don't want to live like that. But as her dementia progresses, she has a very comfortable life. And in her rest home, she's surrounded by friends and family. She's developed a lot of hobbies that she enjoys doing. It would be very difficult to equate her almost with the person that she was before the dementia started advancing. There can be preference instability and inconsistency. People can even change their minds. And also there's quite a lot of evidence that shows that people will have a diagnosis and be like, that's it, take me out to the paddock and shoot me. But over time, people get And actually this research has been shown with people that have been in car accidents and have paralysis. And there has been some evidence, some research in the area of dementia. The particular research I'm thinking about is that with car accidents, it's called the disability paradox. And people that are disabled immediately, they often think, oh, well, just that's it, I don't want to keep going. But as they go on and as they learn to accept their disease, things can be different. Often the future health needs are uncertain with dementia. You can have a lot of comorbidities, you don't really know what it is that is going to be the thing that the medical conditions that you're struggling with later in life. Okay, so remember I said there's advanced directives or making substitute decision makers. Let's have a little look at advanced directives. Just going to make sure I don't talk together. Okay, so I explained this before about advanced care planning in general, but for advanced care advanced directives, when you have the capacity to make decisions, you'll make them to apply at a time in the future when you no longer have capacity. Okay, so people can put a lot into these advanced directives. I'm just going to put my legal hat on for a little bit and tell you about what's going to actually work and what isn't. Because you could make requests for provision of particular care and treatment options. You could say, I don't want any life-saving interventions, or you could say as well, I want requests for removal from life-preserving equipment. Now, in terms of what the law says about it, it's only the latter two that you can actually do to bind other people later in time. I'm not saying that there's no point doing the first one, because your substitute decision maker needs to know what to go on when they're making decisions for you. So this process is very important, but in terms of what you can actually do to bind people in the future, to make it legally enforceable, it's the refusal of medical treatment. And that's because we're in a society now, and a lot of this actually, it's quite fascinating when you look at it. It goes back to even World War II, where people would have experiments done on them. And there's evidence from here in New Zealand with the Cartwright Inquiry and the Tuskegee experiment in America. Yes. So the right to refuse medical treatment and to know about the medical treatment you are going to receive is considered to be a very primary right. It's so primary, it's in our New Zealand Bill of Rights. And that can be contemporaneous. You could go to hospital, you could be bleeding out from a car accident, you could say, I don't want treatment. I'm a Jehovah's Witness, I don't want a blood transfusion. Or you can make an advanced directive. So like Code of Consumer Rights. Who's heard of the Code of Consumer Rights? Okay, and the Health and Disability Commissioner? Yeah? Okay, good. So the Code of Rights gives you the right to make an advanced directive. Now this is where New Zealand's a little bit different from, actually, don't say it. This is where New Zealand's a little bit different from other countries. A lot of other countries have big legislation that will actually set out all the requirements, but we've just got this one statement. You can do it. So we have to look to the common law to actually find out a bit more about how you actually do it. Okay, and I said before what can be covered. So you can cover things like refusal of treatment, refusal of food and fluids. For example, peg feeding, you can refuse that. Pain control, antibiotics, resuscitation. I'm not entirely sure about terminal sedation, so I put a question mark in there, but it's good to keep the academics busy. And it's really interesting. So if you're interested, you could computer at home, put in DNR as tattoo, and you'll get all these things. People get them tattooed here, right here, basically do not resuscitate. Some people get them here saying turn over. You often fall forward, don't you? So, yeah, something to think about. But here's one. Do not put this person on artificial life support of any kind for any reason whatsoever. And do harvest reusable parts. I showed this to my husband before, who was a lawyer, and he could not believe the person who tattooed the signatures on the backs of like that. He was most amazing. Okay, so the legal requirements, as I said, we've got that one line in the Code of Rights. So you have to be competent at the time of creation. You must be free from undue influence. So if someone's actually wanting you to sign something like that because they really like your beach house, then it's probably not going to be binding. It must be intended to apply to the situation, and I think that when we go back to that example of Susan at the beginning, I think that was I wouldn't have really known whether what she said, if I was her husband especially, I'd be like, well, I don't really know if he actually just didn't want antibiotics for pneumonia. My conceptualisation of life-saving treatment was a bit different. And generally, you should actually receive enough information to make a proper decision. But as I've said, there's no requirement for a particular format. We don't have that one line. And there was a while ago in Australia, a case where someone had given an oral advice directive, or someone had just written something and stuck it on their fridge. So while I said about my dad that we really should do something about putting it in writing, he kind of has given me his advance directive now. I just would prefer it in writing so my brothers don't go, what are you doing? Okay, I'm not going to go into this in a lot of detail because it's not, I'm getting to the point where I don't think we need to worry about it so much. We just need to learn from it. There might be issues around enforceability. Judges can be, if it gets to that point, and the issues around enforceability are going to be when people don't agree. And that's when you're going to have the problems. In those cases, there's an expression in law which is hard cases make bad law. When judges are faced with questions of deciding whether or not someone has life-saving treatment, from reading the cases, I would say that they generally favour life. If there's any doubt or ambiguity, they'll go with the life, favouring life. So we just need to learn from this. If it's something that's really important to you, and for some people this is really important, we just need to take the lessons from the cases and make some recommendations about how to do it well. Okay. There's also a lot of a critique about advanced care directives, and this is something that, as I said, people like to talk about. Is it appropriate to bind your future self? Are you a different person when you don't have capacity anymore? This is the kind of thing philosophers like to talk about. And then there's some more practical, some social and cultural factors. We've got to make really sure when we're doing this that we're not doing it because people feel like a burden. Are we treating our elderly people and our people who have conditions as they age, are we treating them in such a way that they really are truly making autonomous decisions? Are we treating them valuably as members of society? And I think that's a really important point for me in the research that I'm doing to consider that point. And does it take into account, especially different cultures, maybe the Maori culture, that actually values shared and family decision making? What do they do when they're presented with the advanced care directive that was stuck on the fridge? Okay, so that's advanced directives in a nutshell. Just check on my time. Doing alright. Okay, enduring powers of attorney. This is a very quick romp through them. Okay, something that most people don't know, and I have to say I didn't know until quite recently, is that your next of kin don't actually have the right to make decisions on your behalf. Now, I don't think anyone's told most of the medical professionals in hospital at this point, and they all look absolutely, when I teach them at university, they look absolutely shocked when I say this. So if you're incompetent, and there's no advance directive and no enduring power of attorney, then it's really up to the health professional to decide what treatment that you get. And they try to take into account your views. Now, how are they going to find out your views? They will obviously talk to the next of kin and ask what your views are, but the next of kin doesn't have an automatic right to consent on your behalf. So, if you want someone who can consent on your behalf to treatment, then what you need to do is make an enduring power of attorney when you're still competent. So then it comes into effect when when that person reasonably believes that you no longer have capacity But for significant matters, things like moving into rest home care or medical treatment, then you actually need to get a doctor's certification. Now, a lot of people don't know that. And for example, I haven't seen on my mother's file whether that certification has been made or whether there's just an assumption. But that's what the Act says. So the role of an attorney, and is anyone here an attorney? Does anyone here have a power of attorney? Okay, yeah, quite a few. Okay, this is your role. Because no one probably told you, because her read closed documents. Font is so small to start off with. So the paramount consideration is that you're promoting and protecting the welfare and best interests of that person. That's pretty clear. And you act in the diver's place. But you also must encourage them to exercise capacity as far as possible. And for me, this is the crux of it. And this is, again, this very bright line between when someone has capacity and when someone doesn't have capacity that the law makes me feel a little bit uncomfortable, especially with dementia. Because people who've got dementia still have a lot to contribute and to express. And I think it's really important that the person who holds the power of attorney and the person with dementia and the health professionals are working together. And they must have regard to any advance directive we make. So again, it's a really important thing to do. But, just so you know, and this is different from Australia, for example, you can't consent. You can't refuse to consent to life-saving treatment. So if a medical professional is recommending treatment, you can't say, and the person with dementia wants, you can't say, oh no thanks, they don't. Even if you think that they actually would have wanted that, you can't. And I think that that's put in there just to protect, as kind of a reluctance to give over those decisions fully to other people. But what's really important about this, and what you need to remember, is that even though the doctor will be making that decision, not you as the attorney, your role is really important there to express the wishes of the person over who you have the power of attorney, because the doctor has to take that into account. Okay, there's lots of practical matters. There's lots of practical matters here. I think especially in New Zealand, I'm not really sure who's responsible for rolling out advanced care directives. I know someone who's a kidney specialist. What's the fancy word for that? Nephrologist? Okay. And she trains people on advance directives. But I'm not entirely sure why she's particularly been tapped to do that. I'm not exactly sure what the government policy is about whose responsibility is. Is it the GP? Is it the specialist? Is it the lawyer? Do we need health input? Do we need legal input? It's just some more work I think that needs to be done with that. As I said, we don't know about the format. We just need to make sure that when we do them, that they can be enforceable. And where we store them. Like, how are people even to know that you have an advance directive, especially if you get taken to hospital really quickly? Should we have a central repository? And, unfortunately, there's a real lack of understanding amongst health professionals. Professor Cartwright begins her talks saying, this is not euthanasia. Some people are scared that we might be veering into that direction, but it's not. So we need to make sure that our health professionals understand what the law says about this and also know what to do in this situation. So we might need, generally the research is starting to say, hey, I think we need a bit more training as this becomes more prevalent. So, there I am. That one. Okay, so these are some recommendations. If this is something that's important to you and you want to do advanced care planning, okay, the first one is choose someone who actually shares your beliefs and agrees with you and is prepared to advocate on your behalf. Involve your friends and family, document it, make it in a place that everyone knows where it is, make lots of copies. It's really important to you, make lots of copies. You could even get the tattoo. I'm not recommending it though, because I think that sounds too painful. Include a mechanism for timely review, because the thing with some of these conditions is they're really long tails. So people might be made 10 years ago, and you might be, oh, I'm not really sure that should apply anymore, I'm not sure they want that. Try to cover as many eventualities as you can and state that you've received all the necessary information. So that's kind of my recommendations for how you can do it. It's something, as I said, that's really important to you. Please feel free to contact me, any of you. I'm happy to have a chat. I'm not, I can't give legal advice because I'm actually managed to escape from being a fully practicing lawyer these days, but I can certainly have a chat if it's something that's important to you. I certainly don't have all the answers, but I'm really pleased that there's actually this dialogue about how we treat people who are dying with respect and dignity. And I encourage you all to be part of it, because I think that that's really important, because everyone's views are important in this. So there's probably no time for questions, because I've probably talked for way too long. But I'll be around, and I'll be around afterwards, so please feel free. And maybe if there's anyone that's included a question that just can't wait, I'm happy to take it. But... Oh, there is one. Goodness.
Can you come back to your original example about the...
Susan.
Susan, no longer known his name. Can you comment on how you said all this?
Sure. I think, actually, maybe just go back one slide. I think the problem is that first just telling her husband that she wanted him to do it doesn't create an enduring power of attorney. So she doesn't have an official substitute decision maker. But she does know her wishes. But if you don't have a substitute decision maker and you've lost capacity, then ultimately, unless you can show you've made an advance directive, I think with the antibiotics, you'd have trouble. I think if it's antibiotics for pneumonia, you'd have trouble, because the cases that I have read are generally, like a woman said something like, I don't want any heroic measures, I don't want to be burdened. And they drew a distinction between her needing hydration and nutrition and being on kind of life support machines physically. Because they said, oh, we don't think that actually went to the nutrition. So I don't think it would be likely to be considered clear enough. And it actually might depend on her other comorbidities and what the doctor really thought about how futile or not the treatment was. But I think the real point of showing that example was kind of like, if that's what you want, you have to be really clear about it.
Thank you.
You're welcome. Yeah.
Hi, Kate.
Hi, Vanessa.
Hi. I have a father with dementia. He's 75, and he has now got to the point, he lives with my brother currently. He's got to the point where we both hold the power of attorney for him, and mental health services in the Bay of Plenty have recommended that he's put into a home. We've chosen not to do that at this point because we feel he's comfortable and happy and well looked after. But if we were to put him into a home and they were to place him, do we lose our rights as the enduring power of attorney, or is it something where we have to just continue to work with services?
So Vanessa's question is, if someone goes into a home, what happens to your enduring power of attorney? It definitely still applies to your enduring power of attorney over him, and they have to work with you. And what I would do in that circumstance is make sure that's on the file. So they're very clear about who they should be contacting and make very clear expectations in that regard.
Thanks.
Yes.
Sorry, I'd just like to say that we're looking for a place to put a loved one in and make sure that they work hand in hand with you at all times. It's a partnership that you're going into.
Okay. Thank you very much, everyone, for your time.